This is Refractive Disease Spotlight, Marfan Syndrome. Marfan Syndrome is an autosomal dominant inherited disorder of the collagen, and it's characterized by loss of elastic tissue. It can affect the musculoskeletal, the cardiovascular, the neurological, the respiratory system, the skin, and ultimately the eyes. It was originally coined a term in 1896, or a disease or syndrome, by Antoine Bernard Jean Marfan. It was described as a hereditary disorder of the connective tissue in a 5-year-old girl. There have been many people over the history that have been proposed to have Marfan's. Abraham Lincoln and King Tut are two of those individuals, where they were unusually large or tall individuals. They kind of meet the actual criteria of having Marfan's. It is one of the most commonly inherited disorder of the collagen tissue, with an incidence of 1 in 3 to 5,000 individuals. So you will see this in your day-to-day practice over the course of years. Its prevalence, though, is about the same in males and females. It's caused by a variety of mutations in the FBN1 gene. FBN1 mutations have been identified in over 90% of patients with Marfan's. 75% of those patients, which are autosomal dominant, the appearance appears in family members, but the degrees of pathology may vary between those members of the family. In 25% of the patients, the mutation occurs spontaneously and may be associated with just the older paternal age. So mutations in the FB1 gene, or the fibrin1 gene, results in the production of abnormal fibrillin protein, leading to abnormalities in the mechanical stability and elastic properties of the connective tissue. People with Marfan syndrome tend to appear tall and thin with disproportionately long arms, legs, fingers, and toes. This damage can be mild or severe, and if the aorta is affected, the condition can become life-threatening. The critical component, though, for eye care professionals is Marfan syndrome does have some ocular findings of critical diagnosis. The biggest one is Ectopian lentis, or lens dislocation. This is such a common finding in this group that's actually a major criteria for diagnosis of Marfan syndrome in somebody. People with Marfan's, though, also have myopia, flat corneas, and hypoplastic iris or ciliary muscles that decrease accommodation and meiosis. Let's first look at the aortic dilation and ectopian lentis, which are major diagnosis criteria. Any change in the aorta is life-threatening for the patient and can be distended and ultimately break and result in a heart attack. Ectopian lentis is when the lens becomes dislocated. In this example, the lens is actually plopped out into the anterior chamber, but typically it becomes dislocated in the posterior chamber and falls out of spot. Well, why does this happen? That's because the iris zonual processes are weakened by Marfan's and they eventually break. Now, if we remember back to our anatomy, the iris zonules actually are what hold up the lens, and that's what actually pulls the lens to allow for accommodation. Eventually, though, if enough of them break, this results in dislocation of the lens. And so absent of trauma, where somebody punched somebody in the eye and the lens became dislocated, this becomes diagnostic for collagen diseases, and for Marfan syndrome is dislocation of the lens. And we can see those zonular fibers here in this picture from a previous paper, where those fibers become strained and they start to break. Ultimately, though, it results in the dislocation of the lens, typically inferiorly because of gravity. Now, obviously, patients with dislocation of like in this example, are now high hyperopes, right? Their lens is no longer in position, so they're now seeing without that plus 20 diopters we'd expect from the lens. Typically, though, these people are actually around 10 diopter hyperopes and not 20 diopter hyperopes. The reason why that is that because of myopia. Patients with Marfan syndrome exhibit high levels of myopia. In this study alone, right, the average was about 13 to 10 diopters, but there was a range of people who were actually all the way up to 20 diopters of myopia. They also exhibit astigmatism, and that's because the cornea itself no longer maintains structure, so it can bend and induce astigmatism. And this is really affecting the model we've talked about previously about myopia development, because it's affecting the sclera. Because the sclera no longer has the proper structure, and the sclera actually contains about 50% collagen by weight, when we actually have the breakdown of this material and we have an improper structure of this material, we get high levels of myopia. And that's what actually allows us to see what's called the blue sclera, where we're seeing the underlying choroid because the sclera has been stretched so much. Ultimately, though, this myopia stretches the eye and puts strain on the retina, and this ultimately can end in retinal detachment. So our role as eye care professionals when it comes to Marfan syndrome are, one, to correct myopia, and this myopia will be progressive and it'll increase throughout the patient's life. We always need to monitor for retinal detachment. We need to decide if we need a referral for IOL implantation with lens dislocation. And we need to consider genetic counseling for this patient to inform them that this disease is inherited. It's autosomal dominant, so to make sure that they're aware that they could pass this on to their children. And finally, we need to consider referring for possible diagnosis when we have ocular findings like dislocated lenses. Thank you.